Well, Chase, how did he do, Chase?
Great. What is supposed to say?
Welcome to this episode of the Twin Sister Docs podcast. I am Dr. Elena McDonald.
And I am Dr. Delana Wardlaw. And together we are
The Twin Sister Docs.
Today, we have our colleague and friend, Dr. Derek Xavier, who is a board-certified medical oncologist. And so with that, we will let Dr. Xavier introduce himself.
I'm Dr. Derek Xavier, a thoracic medical oncologist, which means I specialize in the diagnosis and treatment of lung cancers, head and neck cancers as well.
So can you give us a little bit about your background, Dr. Xavier, where you practice at, how we can get, learn more about you?
Sure. So I'm a proud Philadelphian. I went to Hampton University's undergrad. I went to Drexel Medical School. I'm currently practicing at the Mainline Health Systems, Lankenau Hospital campus, where I'm actually the System Division Chief of Medical Oncology and Hematology. It's a 4 or 5 hospital system. And we do a lot of research, we do a lot of community outreach, and we really try to make sure that all of our patients, regardless of their ability to pay, have access to these innovative modalities to help treat their cancers.
Okay. Can I ask you, Dr. Xavier, what prompted you to go into this field of medicine?
This field. When you're in medicine, when you're in medical school, oncology has like a bad reputation, but you think of like patients who are bald and in this hospital sick, but that's not really the case actually. So we do cure a fair amount of our patients, right? It's really, I call it the perfect melding of science. There's literally breakthroughs every month in cancer, right? Since I've been practicing since 2009, the way we treat all different types of cancers, lung cancers, breast cancers, has totally been transformed. We're curing so many people. We're preventing so many illnesses. So it's this high level of science, but on the basis of it, it's like an old country doctor, right? Because once you have a diagnosis of cancer, no disrespect, we become their primary care doctors. They rely on us for everything.
You are absolutely right about that, Dr. Xavier.
Yep, because I say cancer in their minds trumps diabetes, liver disease, HIV, everything. So we become their primary source of medical care, but also we have to ensure that we're researchers, but also biggest thing, we have to deliver this care compassionately.
And we don't have a problem with the oncologist taking over. And so with that, Dr. Xavier, again, cancer is the C word, is very intimidating to many people, many individuals, to most of us, to be honest. And so one thing I want to really talk about today is lung cancer. Because lung cancer is one of the cancers that we really don't hear a lot about. We associate it with smoking, but it can be, occur in other areas as well. So can you talk a little bit about, lung cancer and...
Yep. So lung cancer is actually the number one cause of cancer death worldwide. Right? Why is that? Because it's caught at a late stage, meaning that by the time you're presenting to one of you guys with the symptoms, cough, coughing of blood, pain, shortness of breath, a lot of weight loss, symptomatic, there's generally a later stage. Not necessarily metastatic, but a late stage. And sometimes you don't have the ability to cure those patients. If it's caught early, it's generally caught incidentally. So, for example, this nice young lady comes in with, a cough. The first thing they do is they get a chest x-ray and they find a nodule. So not really symptomatic, but they, go to ER, first thing you do is get a chest x-ray. They find a nodule, work it up, and has like a small mass that can be removed. That's like a stage 1, early stage lung cancer. That's potentially curable. That's only happens at 10-15% of the time.
That's a really low number.
Very low number, right? So most lung cancers present when they're symptomatic, either locally advanced, meaning that it spreads like lymph nodes, or metastatic, meaning it's spread from the lung to another organ, lung to liver, lung to bone, lung to brain, with seizures. So when they come to see me, unfortunately, most patients have symptoms and they're either metastatic or locally advanced.
So question for me, particularly as a primary care doctor, preventive medicine is one of my major drivers of my job on a daily basis. And so there are lung cancer screenings, but when you talk to people about, oh, I'm going to the doctor, I'm going to get my mammogram, I'm going to get my pap smear, I'm going to get my colonoscopy. You rarely hear people say, I'm going to go get my lungs screened for lung cancer.
Right.
Can you talk a little bit about that, Dr. Xavier?
Exactly. So there's certain criteria for lung cancer screening. You have to have been a smoker. You have to be between the age of 50 and 80 with a 20-pack year history. And you can't have the like symptoms of lung cancer as well. So it's a small criteria, but it's important criteria, right? Because unfortunately, a lot of people still smoke. And if our young kids are, they might not be smoking. We could talk about that later. They're vaping. We don't know what the long-term, disease issue is going to be with that. So we have to really be cognizant of that as well.
Dr. Xavier, I have to stop you right there.
Yes.
If you smoke, stop. If you haven't started, please don't start. And please have a conversation with your teens, even preteens. We know that most people start smoking in their preteens or in their teenage years. And this vaping issue, again, we'll talk about that a little bit later. No benefit to it. Is not better than smoking. So please.
And we tell our teenagers, vaping is just as bad as smoking. So we're telling you not to smoke. We're telling you not to vape. Now, with that being said, Dr. Xavier, can you go over pack years? We talked about pack years as being a risk factor.
Right. So a person comes and says, they've been smoking for 20 years, 1 pack a day. That's 20 pack years. 30 years, a half a pack a day, that's 15 pack years. So this is a calculation. We're trying to guesstimate how much they've been smoking. And it correlates. So the longer you've had a tobacco exposure, the higher your risk of developing cancer. But the thing is, smoking doesn't only cause lung cancer. All right. It can cause head and neck cancers, throat cancers, bladder cancers, like leukemia. So, when you look at what's contained in the cigarette, there's so many carcinogens, so many heavy metals, cadmium, so many asbestos. It's horrible substances, right? So not just the nicotine, right? That's the addictive substance. Right. Nicotine, the thing has come back, but you're exposing your body to all these horrible cancer-causing agents as well.
And the pack says can cause cancer.
Can cause cancer. Definitely causes
cancer.
They're not lying.
And so the screening test, when we talk about screening tests, we're talking about having tests done before you develop symptoms. So that gives us the opportunity to diagnose you at the earliest stage. And so that we can get out of this 10% window that we are unfortunately have where we're diagnosing people at a 10% rate.
So that's what screening is. You catch the cancer early. If you can catch it earlier, you can potentially cure. So that's what it is about.
Can you talk about how lung cancer is diagnosed?
Of course. So initially, it's caught on a type of scan, right? X-ray. X-ray is good. It doesn't give like a really clear picture. It can give you an indication what may be there, right? We generally do like a CAT scan. It's like a two-dimensional sophisticated X-ray. You can see like cuts of the body. It shows like the anatomy, but also shows things were abnormal. So a CAT scan. There's also something called a PET scan. All right. A PET scan is another radiology modality where it not only shows like the anatomy, but also there's something you call it hypermetabolic or active, because the basis of a PET scan is cancer is more active than regular tissues. All of our tissues need glucose or sugar as their fuel, right? The more active a substance or mass is, it lights up brighter on a scan. So when we scan and give a PET scan, the areas that light up bright are areas that we're concerned for cancer. So it's generally a full body PET scan. You can see the mass in the lung had to spread to the lymph nodes and to spread to any other organ. So that's how we get where things are. But really, we have that tissue.
Okay.
Tissue meaning you have to get a biopsy. So you go to pulmonologist, do a bronchoscopy. They go through the mouth of the nose, go and take a camera to the lungs, take a needle and get a sample. They look at under the microscope, and the pathologist, who's a doctor who looks and tells if it's something's happening or not, they say this is cancer or it's not cancer.
Okay.
And based on these, the location, the type of cancer, we stage it. Staging means how big is it, where it is, and we determine what type of treatment is available. The staging determines prognosis and treatment.
Okay. And so Dr. McDonald and I, and Dr. Xavier, we're big on advocacy. But you can't walk into your doctor's office and ask for a PET scan. That's not the initial test that is done. So that is so that is not the initial test. So there's typically a series of tests that are done before you get to the PET scan.
Again, what's good for the goose is not good for the gander. Don't come in requesting certain things based off of what your cousin did, your mother did, your friend did. Because again, you have to have a discussion with your doctor who understands your particular history, your particular case, your particular symptoms to determine what is the next appropriate imaging study that you should get.
Correct. That's true. And the thing is, and we see it all the time. Well, my friend Miss Carol, she had this done.
Mm-hmm.
You can't compare.
No,
you
not
can't
at all.
compare. Your journey, your cancer, your case is totally different from everybody else. And you can't really listen to, we call lay people.
Yes.
You have to give medical advice.
Yes.
The appropriate medical advice, because the issue is you don't want to delay the diagnosis. The longer you delay, the worse your outcome is going to be.
Yes.
Okay. So once we have a diagnosis, can you talk about treatment options, doctor?
Correct. So we can either surgically remove it,
Mm-hmm.
if it's still at early stage. We can do radiation, which is high dose energy that targets the cancer itself. So think of it like a localized treatment modality. So wherever the cancer is, they can shoot a high beam of energy, radiation to kill the cancer. Sometimes we combine it with chemotherapy, which I do. So medical oncology means I give systemic therapy, either chemotherapy, go immunotherapy. We can talk about the difference because there's a lot of questions about what the different treatment modalities are. Or sometimes we can actually give them a pill.
Okay.
All right. So based on a combination of what type of cancer it is, the location of it, how aggressive it is, my team, which consists of a surgeon,
Mm-hmm.
a radiation oncologist, a person who administers radiation, a pulmonary doctor who gets some biopsies for me. We sit down and call a tumor board,
Mm-hmm.
right? And we have consensus about, I think we should do this. I think we have to justify our rationale because we want to make sure that the patients get the appropriate care.
So there's an entire team that comes together
Whole team.
that gives their input, an entire team of specialists
Correct.
who are medically trained to determine what is the next best treatment for each individual patient.
Now, are there some cancers that can be just treated with the surgery and then be done? Or
So in general, if it's really early stage, like stage 1, meaning it's like a 2-centimeter lesion, you can potentially get the surgery and be done with it. Anything larger than that, or if it's definitely spread to lymph nodes, we have to start adding on a different, we'll call it modality, a different type of treatment, either with chemotherapy or immunotherapy. So it's important to make that distinction. What is immunotherapy? Immunotherapy has transformed the way we treat cancers, right? We see these commercials all the time. So what immunotherapy does, it allows our own body's immune system to detect and kill cancer cells effectively. And it is really transformed the way we treat all types of cancers, breast cancers, colon cancers, head and neck cancers, lung cancers. We are getting people to survive lung cancers who would never live, they were, 15 years ago. I have patients who are immunotherapy alive for 10 years. Would have been unheard of before. It's really transformed the way we treat cancer.
So research is extremely important in the advancement of medicine. So immunotherapy that wasn't available 20, 30 years ago has been transformative in the treatment of certain cancers.
Most cancers at this point.
Most cancers.
Most cancers at this point, definitely. And that's why it's important when we hear about the cuts in research.
Mm-hmm.
It's not only hurting us now.
Yes.
It's hurting everybody who's coming behind us, right?
Yes.
If we cut, you think you cut, funding for, no, you're impacting our kids.
Yes.
Because it takes a long time to develop, do the research, get these things out of studies, trial to get them to the market, right? And that, you're talking about 10, 15 years. So you start cutting things now, 15 years, we're going to be way behind.
Exactly.
Way behind.
Exactly.
So, Dr. Sylvia, we talked about, treatment and different types of treatment. Now, many people correlate lung cancer with smoking, but there are some cases of lung cancer that are developing non-smokers. Can you talk about that?
About 20% of lung cancers occur in patients who don't smoke. Generally, younger women without smoking history.
Mm-hmm.
So the median age for lung cancer, meaning that the average patient who develops lung cancer is like in the late 60s, 70s. But with these patients who've never smoked, you're seeing them in their 40s, 50s, right? So they come to a primary care doctor with a cough, weight loss. Everybody's on, GLP-1s, right? So they think, I've been working out, doing hot Pilates, but I've lost so much weight, and by the time they get through the, radiology and finally testing, we find it to be a lung cancer, which really was suspected. And unfortunately, we're seeing it to more and more and more. Mm-hmm. So what are the risk factors for people who are never smokers? Pollution, right? Secondhand smoke, and radon. When you have to buy a house, you have to get a radon detected. So what is radon? Radon is a tasteless, odorless gas that seeps up through your basements. It's caused by a naturally occurring like uranium in the soil, right? And it causes damage to the lung tissue when you inhale it, right? And so that's also a big cause of lung cancer. So secondhand smoke, even though you don't smoke, but if your partner smokes, or if your parents smoke, you can develop lung cancer, right? If you're in an area of high pollution called particulate matter, that's also a significant cause of lung cancer and radon. So those are the type of things to try to mitigate.
So another reason to keep resources available so that we can have those type of elements detected in high concentrations in particular areas. Are there other instances where patients may be exposed to the radon as well?
Not instances, but actually occupations that actually put you at high risk for lung cancer. So patients who have people who work in like waste management, sanitation workers, auto mechanics, right? So you're inhaling all these noxious fumes, and also has a significant increase of developing lung cancers as well.
Okay. So again, it's not just smokers. There's other risk factors that can put you at risk for developing lung cancer as well.
And what is important to drive home here is that you need to have a primary care physician. You need to have your annual physicals. You need to have your annual screenings. And if you have your annual screenings, once you get to a certain age, your doctor can now recommend certain tests based on your age and your risk factors. Because as Dr. Saver has already mentioned, once you start having the symptoms, we're way behind the 8 ball. And the likelihood of actually treating and curing the cancer becomes much, much more difficult.
There's a difference between treatment and cure.
Yes. So let's clarify that.
Yes. I can treat even if it's late stage, metastatic, right? But stage 4 means metastatic. I can treat those patients. I can't cure them. All right. So when a patient comes to me, like literally my job is to educate my patient. Every room I have a whiteboard. The first thing I ask a patient is, what is cancer? You'd be surprised at these answers we get. But I was like, how can I get you to sign informed consent if you're not informed? So we sit there, what is cancer? What are the risk factors that led you to be treating you right now in this instance? We also define goals of care, all right? If your case is curable, but if it's not curable, what are we trying to accomplish? If it's not curable, we want you to live a long life. But equally as important, we want you to live a good quality of life. Equally as important. So if I can't cure you, we want you to live a long time. We also want you to live equally as important, make sure you live well.
So great clarification that when people land in your office discussing what is the path forward, he can treat you, but the discussion of treatment versus cure, 2 very different things. So thank you for clarifying.
And it's also, patients don't come by themselves. They come with their families. So you're not only educating the patient, you're educating the family. So it's important for them to know that the patient can't go through the spiral cell. Right? It's going to really take a whole care team to help patients through this whole process. So it's important that they answer all their questions. The first time I meet a patient and their family, that's like an hour and a half conversation, right? So I have to make sure that everybody knows exactly what to expect. All potential side effects are involved. Also to call them if they have any questions or concern, making sure they have adequate nutrition services, make sure they have adequate social work services, making sure they have nursing support. All these things really can impact the way a patient gets through their treatment.
So again, when you think of the C word, or, as many layman people say, when you think of cancer, the diagnosis alone can be intimidating. And so it's very important, as Dr. Siri said, to have not only these multiple modalities of support from the medical standpoint, but also from the family standpoint. Like you really need that that unit that is going to be able to help patients get to the doctor, make sure that they get their medications, making sure that they're getting their, their groceries. So that support factor is very huge.
We take these things for granted. You can't imagine how a patient who has no support, just getting back and forth to my office is difficult. If you can't get to my office, I can't treat you. That's going to impact them negatively on their treatment. So we have to give patients, transportation services, right? We have to make sure that patients are eating.
Yes.
Right. So we have to make sure that they're, we have to feed them something. I always say this: your zip code should not dictate how well you get treated.
We talk about access on this podcast all the time.
So important.
Everyone deserves not just basic health care, but the best health care possible.
And we do know, unfortunately, that zip codes dictate the quality of care. So, Dr. Saver, with that being said, could you discuss if there are certain populations that are indeed getting diagnosed even in a disproportionate fashion than others?
Well, we are Black folk, unfortunately.
So, unfortunately, yes. And so, can you talk about some of the reasons why?
Man, how long do you have? So, and this actually is pretty sad, right? Because in this country, healthcare is tied to unemployment, right? There's also a factor of how well your ability to pay.
Yes.
And those things, it shouldn't be that way. Everybody should have equal access to healthcare. They should have equal expertise available. They should have equal access to clinical trials is a big thing as well, right? And unfortunately, certain populations, that's not the case. And so if you don't have insurance, if you're uninsured, unfortunately, it's going to impact the care delivery. And we try to make sure that everybody who comes to our door, regardless of their ability to pay, gets that equal care. And that's why it's important to have patients and doctors that look like each other.
Yes.
Right. We need more doctors that look like us because it's been proven, one, they're going to get access to clinical trial, but they will get their care more compassionately and expertly. It's very important.
Yes, very important. And as us as physicians, we have to be in tune to what our patients are expressing, what their concerns are, the medical issues, and those social determinants of health, those non-medical issues that have such tremendous impact on health. And our colleagues need to do that too. So cultural sensitivity or cultural competency is huge. And so, again, so that we can try to address these issues and make sure that people are getting the diagnosis that they need in a timely manner.
One of the things you addressed earlier, I think is very important. You see, older Black men. Doc, I haven't been to the doctor in 40 years. They think it as a
badge of honor.
I said, well, friend, that's not good.
Right.
That's not good at all. If you had preventative care, you may not be sitting in my office right now, right? Have you had your colonoscopy? Have you had a PSS? Right? These things are important. And so that's why it's important that you try to do things on the front end, preventative care, making sure they're following with their primary care doctors so they don't have to come see me. You order their lung cancer screening.
Yes.
Right? You'll talk, hey, don't smoke if you're going to smoke, which you shouldn't. Well, let's make sure you don't develop a cancer in the process. So that's why these things are important, because it negatively impacts their overall health and overall survival.
Yes. And to all the mothers, sisters, wives, daughters, make sure you're encouraging the men in your life to get to the doctors.
Yes, absolutely. Now, Dr. Savior, we have a few more minutes, and can we briefly talk on head and neck cancers and how we can prevent that? And
so these are cancers of like the oral cavity, like tongue, tonsils, the larynx, the voice box, right? The risk factor is almost the same as lung cancer, smoking. So the actual incidence of smoking is actually going down. So you would think there's a bit of corresponding decrease in head and neck cancers, but it's not. It's actually increasing significantly. So if it's not smoking,
what is causing it?
HPV.
Okay. So
HPV virus.
Human papilloma.
And so what's happening is you're seeing this virus, really getting, infiltrating the tonsils or base of tongue and causing these horrible, horrible cancers. in general, head and neck cancers are caught later in life, 60s and 70s, but these HPV associated ones are caught much earlier, 50s, 40s, with that. So it's got a mass in like called the base of the tongue or the tonsils, and it spreads to the lymph nodes in the neck. Right. So that's generally how they present it. You start with a large, swollen mass in the neck, difficulty swallowing because of the pain. You go to the doctor, they see a massive biopsy it, and then surgery, chemotherapy, immunotherapy to try to cure. But we have to be able to bend the curve to ensure that patients don't develop that.
Okay.
So if patients hopefully start to get vaccinated.
Yes.
Right?
So there is a vaccine against the human papillomavirus, and it is called Gardasil, and it protects against certain cancers, including head and neck cancer from the human papillomavirus.
Anal cancers,
vaginal cancer, cervical cancer,
anal cancer,
all of those cancers, Dr. Xavier is correct. We have a vaccine that has been well established, that has been out for just about 20 years. And we start vaccinating our children. You can start as early as 9 years of age. In our practice, we start at 11, but the goal is to vaccinate before you become sexually active. And the earlier you vaccinate, the more your immune system responds to it. So it is key. Please, parents, talk to your pediatrician about making sure that your preteens and teens are vaccinated against the human papillomavirus.
So the question, I'm sure people want to know, how does one get HPV in their throat?
Yes. And so we're going to address the elephant in the room. It's oral sex.
Yes.
And so you have to be aware of these things to know that if you're having oral sex or you're not using protection, you can ultimately be at risk for developing HPV in your pharyngeal area, your mouth area, your throat area, and develop head and neck cancer.
Yes. The virus is endemic.
It's everywhere.
We don't know which patients were going to be infected with the virus and develop the cancer.
Yes.
Because most of the time we can clear it. Obviously, if you're vaccinated, the clear is better. So we don't know which patients will get the infection actually. So that's a hot topic of research. But since everybody's having sex, right? You want to be able to protect yourself.
Yes.
You really have to vaccinate children.
So as physicians, we have to do our part. But as individuals, you want to do your part to give yourself the best chance to fight any cancer that you potentially develop.
Treatment for head and neck cancer, if we have time for that, Dr. Xavier.
Yeah, so we can cut it out. We can irradiate it, combination of it, chemotherapy. Head and neck cancer is particularly interesting case because it affects swallowing.
Yes.
It affects breathing. We see people with the tracheotomies. It affects cosmesis, how people look, right?
And that's a big one.
It's a big one because, sometimes they have to do significant, resection of disease. They have to reconstruct the jaw. So there can be a very morbid cancer, right? It's one of the things that, we think about cancer as one of the ones that really impact quality of life because sometimes you're not able to eat anymore. You have to get all of your nutrition through a feeding tube. You can't breathe on your own because they have the blockage in your throat. So you have to breathe through your throat. Yes. So it can really affect your quality of life. Right.
Well, Dr. Xavier, thank you so much for joining us.
Thank you, Doctor.
Our expert oncologist here. So we want you to take this information, discuss it with your personal doctor, and make the decisions that you all need to make.
Thank you for tuning in. We'll see you on the next episode of the Twin Sister Docs podcast.
Thank you.
You did great. Thank you, dear. Thank you, Doc. Thank you, Doc. You did great. You did this like 15 times already.